So we're going to go straight into the panel discussion with Dr. Hart, Dr. Kim, and Dr. Kibule. So I want to try to have a better understanding of, like, from my perspective, the oblique is a great approach, but it brings in other aspects of anatomical structures that typically spine surgeons don't have to worry about, including vascular and peritoneal structures. So Leonard, what's your thought process behind doing a direct lateral versus an OLIF? Like, have you converted 100% into doing OLIFs now?
So when I look at my cases, it's typically two types of cases, or three, that I'm doing. It's either an ALIF, an OLIF, and I'll do the occasional TLIF. And the way I typically break it down is, number one, patient's anatomy. Is it feasible for me to get into that disc space, especially at 4 or 5, based on that patient's anatomy? If we have vasculature that's in the way, sometimes it may be more advantageous to do an ALIF, okay? And I'll typically have my access surgeon obviously assist me with that. Or oftentimes, if I'm doing these cases, or if a surgeon is doing it for the first time and you're seeing that vasculature there, they may be more tempted to do a more direct DLIF or an XLIF in order to try and stay away from it. Now, what I've come to find out is I'll still do my OLIF approach. I'll actually go in and I'll actually see the vessel, and I'll move the vessel out of the way and I'll protect it. And I'll also see the psoas muscle, and I'll move the psoas muscle out of the way and protect it as well, and kind of create that corridor. So, but there's no shame in going through kind of the anterior-most portion of the psoas muscle. When we say anti-psoas, that's the preference, but there are still times where you may encounter the muscle fibers. But the main point here is we want to ensure that we're not retracting that psoas muscle very posteriorly for an extended period of time. The other structures that we always look for when we're doing these particular cases are, where is the kidney? Is the kidney in my path of performing my OLIF or even performing my XLIF? And so we have to recognize that. We have to recognize, other structures that may impede our ability to get to that space. For instance, if the patient's had any type of retroperitoneal procedures done, or if there's mesh in that way, it may certainly make it more challenging, and you may want to consider doing a TLIF or even a more traditional ALIF procedure.
Great, and I want to introduce my partner and spine surgeon extraordinaire, Dr. Bob Hart. Bob, I know that you do more OLIFs than any one of us in our practice, and I think you made that transition a few years ago, and now you're pretty much all in to OLIFs. So could you tell us a little bit about the technical and safety issues related to OLIF versus doing it through a direct lateral approach?
Sure. Is this on? Yeah. So first of all, thanks for including me, Jeff. It's a wonderful course, and I'm delighted to be part of this symposium with a very experienced and talented group of surgeons and colleagues. So really a pleasure to be here. I'm old enough that I still am mainly an open surgeon for most of my work, but I am also old enough to remember when the XLIF was first popularized, and I started doing it almost immediately. And one of the things I try to teach our fellows is how to recognize or developing personal barometers for new technology that they think is going to actually add value to their practice. And for me at that time, the XLIF seemed like an obvious way to add value, because the traditional open approaches were really very morbid for the patients. Just a lot of pain, a lot of devascularization and denervation of the abdominal walls. And so to be able to do this percutaneously made clear sense to me. And I did find that it did add value, but I also found that in my first 10 or so cases, I had a couple, and they were both at 4 or 5 that came up with a femoral nerve palsy, and one of them quite dense, and both of them, despite the stimulation, I followed all the protocols, and yet both of them woke up with just a really weak quad. And I know one in particular, gentleman that just never fully recovered and was very unhappy with his result as you know, due to that complication. So following that, I sort of put doing 4-5 on hold, and of course 5-1 was never part of an XLIF procedure. And but I continued to use it for 2-3 and 3-4 with good success, and have always liked that. But then again, when the OLIF came out, again, for me, it was one of those sort of aha moments that it seems obvious now, you know, why didn't we do it that way before? But it took, I guess, Rick Hines, and I don't know who else was involved in kind of developing and popularizing the procedure, but for me, it was an obvious improvement over an XLIF. And so at that point, I began to use OLIF in place of XLIF, and I've continued to do so. Now, despite liking it as much as I do, I have not yet used it for 5-1, and I keep watching these presentations and thinking, you know, I want to do that. But I do 4-5 a lot of times with an approach surgeon still now, just because I think it adds safety in my hands, in my OR. Not always. I do 4-5 on, without an approach surgeon at times, but I do think, you know, the complication. I will say one further thing, and then I'll turn the podium over to one of our other participants. But I think that there are significant complications. We all recognize that, and you know, I think we all know of complications including bowel injury, ureteric or kidney injury, vascular injury, and still neurologic issues. So neither of these procedures is risk-free, but I think in experienced and careful hands, they're very effective and very safe, and they still are a much better alternative to the older approaches, older open approaches that they have replaced, and I certainly see OLIF as an advance on the traditional XLIF or the original XLIF transpsoas approach.
So Bob, you let the cat out of the bag, and so we're going to talk about something a little bit controversial here, and Sean knows exactly where I'm going to go with this, is that, like, if you think about ACDFs, none of us very rarely would ever think about bringing in an ENT surgeon to do the approach for us unless there was some sort of like wound issues, you know, previous radiation, difficult type of anatomic considerations. But it seems like now, like as we shift the focus from like laterals to oblique, and this, which is kind of in between the anterior and lateral corridors, there's this question of whether or not we even need an approach surgeon. Certainly you don't for a lateral, 100% should for an anterior, but in this oblique, it's this gray zone. So Sean, how did you come upon this, where I know you've had experience in the past like doing your own exposures, right? But like, do you feel that this is a temporary thing where we're just getting comfortable with the anatomy and the complications, and eventually will we all be doing these approaches on our own, especially at 5-1 I'm talking about?
Yeah, Jeff, I know what you mean. It's, you know, when you think about OLIF, it is no different than XLIFs or DLIF procedures. And only difference is matter of your initial approach. You go in front of the psoas muscles, it is, you know, OLIF procedure. And early on, Jeff, I saw your demonstration. You were performing lateral approach, but you're still dissecting it, and you're going anterior to the psoas muscle. So that's basically OLIF. The only difference between what you are doing, the OLIF procedure is, in OLIF, the incision is going to be slightly more anterior, and your incision is still going to be in the middle. And the advantage of that is, in the OLIF, you identify all the structures that you want to protect. So that's basically peritoneum, that's a ureter, and that's a vessel. In the lateral procedures, you kind of rather not see it, and you perform these procedures. So that's the only difference. And we are using, Bob, you're using the, you know, approach surgeon for even for 4 or 5. I think it has a lot to do with the familiarity. And when I was first doing an XLIF procedure back, 2005, I used to use approach surgeons too. And after performing about 1,000 levels of the XLIF procedures, using an approach surgeon seems to be preposterous. And so to me, it was a natural transition to perform XLIF at the beginning with approach surgeon and later on without approach surgeon. So it was easier for me to initiate OLIF procedures without ever using approach surgeons. But I know it's not going to be the same for everybody. So I think it all depends on experience. And as the surgeons get more experienced, as we introduce this kind of procedure in the fellowship, such as SSF, and newly trained surgeons got to be a lot more confident and comfortable doing the procedure without an approach surgeon. That being said, L5S1 is a slightly little different, and I think, as I mentioned previously, that it's still a good idea that you perform OLIF procedure. First 50 cases or so with an approach surgeon. And then when you're absolutely comfortable with the anatomy and you know what to do if the complication occurs, then you can transition doing procedures on your own.
But Bob mentioned that there are complications that can occur, which you don't experience when you're going through a lateral approach, and that's one of the reasons why we don't need an approach surgeon when you go lateral and anything posterior to that, right? So where do you draw the line? Like, I think that what Bob's trying to say is it depends on the standard of care in the area, Like if it's a standard of care to use approach surgeons in a certain area, I think that dictates from a legal standpoint, maybe, But if you're experienced enough to be facile and comfortable with that exposure, then I think it's something that it's based on your knowledge and experience, right? So Bob, do you think that at some point that transition will go from approach surgeon, even at 5'1", to spine surgeons just doing the surgery like an ACDF?
Yeah, I certainly am always careful to use the phrase standard of care, and I don't think, speaking for our region, I guess, I don't think that I would argue that the standard of care needs to include an approach surgeon for sure. My personal experience, I'm part of the reason I went into spine was I liked general surgery and I liked abdominal approaches, and so spine offered something similar to that, and I really enjoyed doing those approaches when I first finished training and feeling like, I could manage that and do that kind of surgery, and it's unique within orthopedics, right, in a very substantial way. And at a certain point, I just began enjoying having an approach surgeon present. And I'll own, I've had great friendships with almost all of my approach surgeons, and I'm thinking of 2 or 3 in particular, one of whom was my wife, so I've got to include her on the list. But at a certain point, it just was more fun for me to do the cases with an approach surgeon, and I've continued that, and I still do. And I still do ALIFs at 4.5 and 5.1, as I was saying, and so for me, that's definitely something I want to do with an approach surgeon, not on my own. So I think we all develop our own kind of comfort zone and maybe our own, again, I don't want to call it standard of care, but our own standard approach to how we are most comfortable doing these procedures.
How about you, Leonard? Can you give us an idea from your perspective? What was your thought process of going from lateral to an anterior to the psoas type of approach?
Well, I'll tell you my story. So when I first started doing lateral procedures, I grew up. I'm not that old, but I still remember the age of the XLIF, and I grew up doing a lot of XLIFs for my patients. And there was a smattering of cases where getting to 4.5 was quite challenging, and it was just so much easier at that point with all the difficulties to just say, you know what, I don't like having this conversation with my patients. I don't like this idea that I may not be able to get in a good big enough cage adequately at 4.5. And so I just transitioned back to doing ALIFs, and we have a great access surgeon here in DFW who will get you down to 4.5, 5.1, any single level in literally 8 minutes. and you will get through it and blast through that case, and it'll be a very well done case. But the challenge is when you find that one access surgeon who's that talented, guess what? Everybody in the city wants to use them. And so now scheduling becomes a challenge. And so you're working with his schedule in order to get all your patients on the schedule to be able to have the procedure done. So it's funny. So one day somebody, one of the Medtronic reps came up to me and said, "Hey, have you heard about this great procedure?" And I kind of laughed it off. I said, "Yeah, no, I'm sure it's like, the usual DLIF. I don't need to learn that. I've got an access surgeon. We do a great job there." And so I had the same aha moment. I went into the lab. I saw the procedure. I was like, this is actually really transformative. It really checks off a lot of things that I've had issues with when I was doing a DLIF or an XLIF. And then within the week, I actually invited my access surgeon who hadn't gone to the course. We did an OLIF procedure at 4.5. The following week, we did an OLIF 4.5.5.1. We actually hadn't gone to the course either. And it was really a transformative day for me. And then ever since then, I have never gone back to doing a traditional DLIF XLIF. Now, I can arguably say that at 2.3 and 3.4, you're still basically doing a DLIF XLIF. And as you can recall, when they first started teaching the XLIF to us, they would always tell you, hey, if your implant is too posterior, you need to bring the retractor more anterior in order to get it, at that 50-yard line. That's basically an OLIF. And so now what's happened with my practice is I'm able to get more patients on the schedule. I've learned how to do 2 to 5 on my own. I don't have to worry about calling my access surgeon and wrangling with him, hey, can you squeeze me in? I've got 5 patients we need to put on before the end of the year. I only call him if I need to do 5.1 and add 5.1 to the case.
And then a final question for all the panelists. What do you guys do at the thoracolumbar junction? T12, L1, L1, L2. Preference for side, left versus right, and other anatomic considerations.
Jeff, for TL junction, I do lateral approach, and I do retroperitoneal approach. And if the diaphragm is high, and I go under the diaphragm, diaphragm is high. If the diaphragm is low, I do lateral pleural approach. So in that case, I find it very helpful to have a one rib resection. And for instance, if I'm gonna do a procedure at, let's say, T12L1 or T11, T12, and then the level happens to be either right at the junction of the diaphragm, it is proximal to the diaphragm. I make basically take out the segment of rib and elevate the pleura anteriorly and do the lateral approach. And I find it very, it's a lot easier than you think.
But I'm saying, do you use a true MIS percutaneous approach or like a mini open so you can actually see all the, like you do for an OLIF?
I think it is a semantic. My incision size is about 4 centimeters. So is that a MIS approach or is that a mini open approach? I mean, MIS approach, when you think about it, OLIF and that, XLIF, it's all mini open procedure, is it not?
Bob and Leonard?
I'll typically do the same. I'll call my access surgeon to be there to provide me access. If the diaphragm it needs to be taken down, I'll have him assist and take that down. My preference again is to do, if I can, small incision in order to try and get into that retroperitoneal space if at all possible. And then on occasion, I'll also, kind of do my traditional TLIF as well. If it's, if it's one single level that I need to add and I'm doing kind of a traditional OLIF with the other levels, I'm able to gain access. It's just one level. I'll TLIF it if I absolutely need to as well.
And Bob, do you have a limit on what level you'll go to? Is it L2 through L5 with respect to your OLIFs, or do you go to thoracolumbar junction and then do you bring in an approach surgeon for that?
I don't ask for an approach surgeon in the upper levels, and I think that up to T11 or so. And I agree with what Sean described. I'll cut a rib or cut about a 2 centimeter segment out of whichever rib is most directly over the disc space. And if the diaphragm needs to be elevated a bit over the disc, I'm comfortable doing that. I don't think it ends up needing to be repaired. I haven't seen any residual effects from that in my patients. So anything above 4.5, I'm always doing by myself. 4.5 for me, if it's only 4.5, is kind of on the bubble and just depends on schedule and the particular patient. And then if I'm doing 5.1 and 4.5, I would always have an approach surgeon and typically do both as an ALIF.
And one question that hasn't been answered yet is left side versus right side at the thoracolumbar junction.
I go from the left for all of them.
Sean?
It doesn't matter, but let's say that if I'm just doing a thoracolumbar junction one level, then I could go from the right or left. Probably my preference is left because that's the side that I'm used to. However, let's say if I'm doing a scoliosis correction, and if I'm gonna be doing, let's say, T11 to S1 fusion, and it depends on which level is more favorable for me to approach for the lower level. For instance, if the vessel is significantly prominent on the left side, then I'll be approaching from the right side. If the vascular structure is equally favorable and unfavorable, then I usually approach the side of the concavity to perform the procedure.
Yep. Leonard?
Yeah, I agree with Sean. It really depends on the curve. My preference is to be left-sided because that's where, most of our patients are situated with the left side up. So, but if we're doing curve correction, then I want to go on the concave side rather.
And just like one final word is just like you would get an MRI and or CT scan at L4-5, L5-S1 to see if there are any vascular issues, you should really take a very close look at the thoracolumbar junction as well, because you'll see that oftentimes on the right side of the approach, the liver will actually be in the way, so it will not really be accessible. And then you also want to see exactly where the kidneys are located. Typically, if you tend to rotate the patient a little bit away from you, the contents tend to, even the retroperitoneal contents tend to go a little bit away from the spine, so those are important considerations. Well, listen, I want to thank everybody for hanging tough. This was the first time we ever did a virtual MIS symposium, and I thought it went really well. First of all, thank you to all of the faculty members. You guys are like superstars. To all the audience members, you already know this, but some of these folks are just like the top MIS surgeons in the world. And so we were really, really fortunate to have such a great variety and a group of spine surgeons. Thank you so much to the fellows for helping out today and learning and teaching. We learn as much from you guys as you learn from us, believe it or not. Thanks to the staff and team at SSF. And finally, thank you so much to all the corporate sponsors. We couldn't do this without you, and we look forward to next year to doing it in person in Seattle, Washington during the summer. All right. Bye now.